Hey, welcome back, guys and girls. We're going to go talk about the structure, function, and common conditions of the musculoskeletal system today. So let's jump right in. Click the right thing. Okay, basically what we're talking about is bones and muscles, but also the kind of things that connect them. So when we were in fifth grade or whatever it is, and we learned that bones make up well, actually, my son knows that bones make up skeletons, and skeletons are what holds the body together. He's like 4. So we learned this stuff early on, but we don't always understand that bones play a very important function in other things, such as that bones actually regenerate. They're not just there as this static thing that holds together, but they actually grow and they can heal if they get broken, right? Like that makes sense when we think about that kind of stuff. They have important metabolic functions, and they also create or form blood cells inside the bone marrow. So we've talked about that before when we talk about immunities. So they aren't just the thing that holds our body together, but they also create things for us, and so they're really important for that sake. When we think about things like amputations, potentially like amputations from the hip, those have consequences, not just like, oh, you can't walk, but you also have to think about then, how do I support the immune system if that important function of the bone isn't there? So you can kind of see how this can get complicated pretty quick. When we talk about connective tissues, we're talking about a bunch of different things. So first of all, we're talking about ligaments, and those are the things that connect bone to bone. By the way, before I get too deep into this, I'm going to breeze over this stuff for the most part, because this is just sort of the medical background. You'll want to know this stuff in order to help people with these kind of conditions that affect these things. But again, this is just brief overview. So ligaments connect bone to bone at a joint site. Tendons connect muscle to bone. Cartilage is there to it does a couple things. It maintains structure, so in order to have adequate space, like between your knee joints, you have to have some cartilage there. It just allows for things to sort of move and be fitted in the way that they're supposed to be fitted. So one could say, well, we can just replace cartilage with something else, and that something else has to be the right space and the right, what's the word? The pinching doesn't really help me. It has to have the right amount of bounce. That's not the way to say it. But hopefully you know what I'm saying. It can't be too squishy and it can't be too hard. It has a structural function as well. But also the thing we know cartilage for is its cushion. So we know cartilage is in our ears and our nose that provides that structure, but it also is cushioning for things like our knees and in between our vertebrae and that kind of thing. And then bursa. Bursa is a connective tissue, and it does more of that kind of like if you put lotion between skin so it doesn't rub, or maybe like petroleum jelly or something, so that the skin doesn't get irritated. That's kind of what bursa does. It fills with this, that's like a little sac that fills with synovial fluid, and it's there to prevent friction. So especially between like bones and tendons together, bone and skin, places like that. So those are the connective tissues. One of the most helpful parts of this chapter is understanding the terminology around articulation. And what I mean by that is just the way a body moves and the directions it moves, that kind of thing. In fact, let me go to page 399 so I can look at this with you. And I'll talk about a few of these. You might want to pause and go to your book if you haven't already, if you don't have it in front of you. There's a bunch of language there, and I didn't want to put in a whole bunch of these things just for the sake of spacing, and you have the book so you can go look at it. But it's really, really helpful to understand the movement of the body, because movement conditions are going to be a big part of being able to read medical records. When you say, somebody has lost the ability to move in this direction, well, moving in that direction, the technical words, some of which we'll see here, the technical words you might only see in medical record, but how that applies to a person's actual job and their ability to function at that job is really important. So if you understand the doctor saying like limited abduction potential in the arm, that means, as you can see here in the second part, or the second bullet point down here, the abduction is movement away from the midline of the body. So if a person has reduced abduction in their right arm, that means they have a reduced ability to move their arm outward, something like this. So this can be really helpful to be able to read this, or be able to understand these terms so you can read them in medical record. chances are probably good, instead of just like memorizing this list, when you start seeing these medical records and reading through these, know the list is there, and then you can go back and reference them, or keep your phone by you so you can Google them, and just you'll kind of absorb these over time. But it can really give you the heads up if you look at these and start to memorize or internalize or contextualize how these terms are used. They tend to happen in pairs, and so we'll talk about this pairing thing now and a little bit later as well. But flexion is bending and extension is straightening. So think of it like, when you flex your muscles, you're like, and you flex this arm and you sort of bend it up this way, and you can see, I'll show this, I'll do this on camera. See that muscle? You don't, because I'm an academic, I don't have muscles. But if I did, you'd see a muscle there. When that muscle flexes, it bends and pulls the arm upwards. And then with extension, it extends it out and it straightens the arm. So flexion, extension is just two sort of complementary movements. Abduction, like I said, is movement of the body away from the midline, where adduction, not abduction. Adduction is moving it back toward the midline. So if I lift my arm, I abduct, and when I lower my arm, I adduct. Same thing with the leg. You can't see that right now. In fact, there's a really funny picture on the next page. I'm going to move my camera down for this because it's funny. There's a really funny picture on the next page. And you kind of won't see this because you can't see my legs down below here. But there's a picture of a guy. In one picture, he's swinging both his arm and his leg across his body like this. And the funniest part about it is that he's holding his hand out like this. And I'm just picturing like jazz hands. It just was a funny image. Looking like he's dancing a little bit. So anyway, let me move this back up because the green screen looks a little weird when I do that. And then pronation versus supination. That's another one that I see commonly. So kind of one that I just want to put on here. But pronation is movement of a body part downward. So if I put my hand down, that's pronation. It's also kind of extension and pronation as well. It's kind of doing both things. So it's straightening and moving downward. Also with the wrist, if you pronate, it's putting it down. And then supination is moving the body part upward. So you could look at it like this too. Supination would be this direction or this direction. It sort of depends on the way you describe it. So that can be really helpful to know that kind of stuff, because you will see a lot of movement-related disorders, especially when it comes to the next chapter we're going to talk about, which is pain. So anyway, there are different kinds of muscles. We've probably learned this before too, but there are the involuntary muscles, like our cardiac muscles, our digestive tract. I talked about that in a previous lecture. They do things automatically without us having to think about it. Then there are the voluntary ones, the ones that we kind of know. So we can say, okay, I need to move my arm. I think about it. I'm volunteering my movement of my arm and I lift, right? Different kinds of muscles, and this is again where they're kind of pairing. So we have flexors. Those are the particular muscles, not the movement necessarily, but the particular muscle that bends a limb. So our bicep would be a flexor. And then extensors. So there's two of them, one on the bottom side, the tricep and the bicep. They work in unison together to lift and straighten, that kind of thing. Same thing with adductors, to move a limb closer to the body. Dorsiflexors bend the body part backward. It's just for reference to that specific kind of muscle that we're talking about there. The one thing to note too is that muscles maintain partial contraction even at rest. And so one of the questions we can ask ourselves is, what does that mean for stress and anxiety? And what I mean by that with the question is, if muscles maintain a little bit of contraction, what happens when they maintain too much contraction? In other words, when we experience stress, we kind of tense up, right? And we carry a lot of stress in our neck. When we say things like we carry stress in our neck, it means our muscles are like more contracted than they're supposed to be. Part of the intervention of relaxation exercises is to help our body kind of lower the resting contraction rate. It's just a scientific, therapeutic, like physical therapy way of talking about what does it mean when we say we carry stress with us and we carry it in our muscles. Part of this is we can voluntarily reduce the contraction of our muscles. That's the whole point here. So stress in our lives, just in general, builds up muscle contraction. And the whole point is that our muscles are just like tired. They're just exhausted, right? And they do weird things. They hold little pockets of, uh, what is that called? Some kind of acid in your muscles. You can tell I'm not a too much of an athlete. Lactic acid, I think it is. When you get massages, if anybody does massage therapy or anything in this class or watching this video, part of that, what you'll hear from massage therapists is that after you get a massage, you want to make sure to drink a lot of water to help flush out a lot of that lactic acid that's been building up in your muscles. So that muscle contraction, it hangs on to some nasty chemicals, and voluntary or mechanical massage or voluntary relaxation exercises, those kinds of things can help your muscles relax and not contract so much so they can actually not be so tired, right? So it's kind of in the ballpark of what we're talking about here. So let's talk about some of the conditions. First of all, one of the things to know is that these could be primary conditions or very often secondary conditions too. So individuals with chronic conditions are maybe more susceptible, and depending on the condition, it might be more susceptible to things like fractures. So if you think of like osteoporosis or cancers or something like that, demineralization of the bones. So a condition might have a secondary cause of sort of, for lack of a better way of explaining it, blocking the regeneration abilities of the bone. So things don't heal as fast. They don't do sort of on normal cycle. They don't replace the cells as fast as they should, stuff like that. The book describes a whole bunch of different kinds of fractures. I've never found it incredibly helpful to memorize all that stuff as far as what kind of fractures, because by the time they see rehab counselors, the majority of people have already gone through that. You'll see these terms in medical record and that kind of thing, but what we're more interested in is the functional implication of after this fracture is healed, or if it's healing, what kind of things like range of motion and stress tolerance and ability to lift and that kind of stuff becomes a little more relevant to us as rehab counselors. As therapists, I can't think of a time when you need to know what kind of what a compound fracture means. I just don't know why that matters to you and your job. So there's closed, open, complete, incomplete, transfers, complicated, and a whole bunch of other terms around there. They're in the book. Know that they're there for a reference, but there's all kinds of ways of describing it. So I don't know. For what it's worth, you can dig into that one more if you feel like you need to for your particular job. But for the majority of counseling jobs, you probably won't need to know that kind of stuff. Dislocation, when we hear that, we think of separation of bone from joint. So usually tearing of all kinds of potentially ligaments and tendons and that kind of thing. We hear about that commonly in the arms, elbows, knees, those kind of joints, hips sometimes. Contusion, what that refers to is a soft tissue injury from a diffuse blow. So like if you give somebody, what is that called, a Charlie horse? You give a Charlie horse in someone's arm or leg and someone punches you or whatever, it hurts. And there's two kind of potential things that happen. One of them is you could potentially get, not only does it just like, it's annoying when people hit you, but also bruising happens, it can happen, which is the breaking of the blood vessels that lead to discoloration. Everybody knows what a bruise is, right? The reason there's a different name between a contusion and a bruise is because you could also get a hematoma, which is a blood sac that fills up underneath the skin. So then it doesn't just discolor, but it fills up with blood. In fact, I had a blood sac fill up in my ankle one time when I was playing soccer as a kid in high school. It was like from my ankle about this high up my leg, which is, almost to my knee, not quite, but like the top, if you had like, tall socks, it kind of went up there. And it was really weird because I'd put on some socks that weren't even that tight, but they were like, had a little bit of elasticity or compression. And that little blood sac would kind of go fill up all the way up into the top of my calf. And then I'd take my socks off, and over a little bit of time, it would slide back down. You couldn't tell because there was no discoloration, but when you put your finger in it, it would like maintain the impression of my finger, which is really fun. So I'd sit there and like poke at it because I couldn't feel it. It didn't hurt or anything. I just had to like kind of wait until it went away. The body would sort of reabsorb all that stuff. So anyway, now that I've officially disgusted everybody, talking about blood and blood sacs in your ankles or whatever, let's move on. Strains and sprains. If you've ever played a sport, you probably have heard both of those terms. A strain is an overstretched tendon. Remember, those are bones to muscles. Sprains are overstretched ligaments at attachment sites. So, like, your ligament might come off a little bit or something from your bone. I just had a moment of like brain fart because I just want to make sure that I was saying the right one. Yeah, ligaments are bones to bones, right? Bone to bone. So a sprain is then detachment from a bone, basically. Okay. Laceration, a cut, tear, or elongated puncture. Not much more to say about that. I don't know why we don't just use the word cut because it can just, it's not exactly very descriptive because it can describe like puncture wounds and all that kind of stuff. Bursitis. So we didn't spend a lot of time talking about the bursa, but remember those sacs of synovial fluid at a joint? It's when those sacs can get infected and inflamed, and they can cause pain, and we'll talk about pain in the next chapter too. But bursitis is a kind of an infection of that space. Tendinitis and tenosynovitis. These are two things that typically happen together, as it says here. Tendinitis is an inflammation of the tendon, and tenosynovitis is the sheath around the tendon when that gets inflamed. But they typically happen together, so I don't know. I can't think of why that's important to know exactly the difference, but nevertheless, what you can kind of understand here is that there's all these different moving parts when it comes to what can happen at a joint or in a muscle. There's the muscle itself, and then there's these protective layers and some cushion sacs like cartilage and like the bursa, like all those things. So there's different locations and complications that can happen when things go wrong. That's kind of the idea here. Something that you will probably see if you work in rehab counseling and you talk to people about the functional limitations of their job is carpal tunnel syndrome. What that actually refers to is that the nerve actually kind of, I don't know if this is exactly technically true, but the nerve goes kind of through these little tunnels, for lack of a better term. Carpal means finger, by the way. Carpal tunnel syndrome means the nerves that go into your fingers because of the repetitive movement in your wrists, like people who work at a computer all the time and they're sort of rapidly typing, unless they use some ergonomic keyboards and some wrist rests, things like that. This is a condition. My mom had this. She was the secretary for years and then became an administrative assistant when secretary was no longer politically correct. But she had carpal tunnel surgery because for years she just spent typing on a keyboard. It's just the thing that causes pain, tingling, numbness in your hands, and can be kind of distracting and keep you up at night sometimes if your hands are more prone to going numb at night, something like that. So caused by overuse of hands or awkward movements. That's kind of like, by the way, some keyboards, this is how nerdy I get. I was watching a video the other night on keyboards and ergonomic keyboards and different designs of keyboards. And you've seen those ones that kind of move instead of having a keyboard that's straight across, you have them that they're sort of two hand positions because it's more ergonomically correct for your hands to work that way. And also there's some that sort of rest your hands over the top and just like there's different configurations of keyboards. And those are the kind of things you see as a result of let's try and avoid carpal tunnel syndrome. So if you ever work with anybody like this, you might get introduced to different keyboard layouts because there's a lot of people who use those to either prevent the future condition of carpal tunnel syndrome or manage the pain and numbness and tingling that goes along with it, either before or after surgery or whatever. It's not just typing though. People who are sign language interpreters have to kind of worry about this as a condition of their job, which is, constant movement of the hands can cause these kind of things. As far as management for this kind of thing, I mentioned, changing keyboards, using different ergonomic devices if it's something you use commonly, but also just like putting a hand on a splint can help out with this kind of stuff. Reducing the use of the hands if possible. So this is where if it were to become such a condition where, like, if you were a secretary and you said I have carpal tunnel syndrome and it's really impeding my ability to do my job, then potentially reduced use might mean finding a different kind of job where you're not using your hands as much, or finding other ways to communicate, or voice dictation or something like that. Those are all other options to help out with that. Also, steroids, surgery, those are kind of common responses to any kind of musculoskeletal thing, which we'll talk about a little bit more here too. We mentioned osteoporosis, which is frail or weakened bones due to reduced mass. So the bone just doesn't have the same, doesn't build up a strength, kind of. It just sort of doesn't really shrink, but it reduces the mass by not regenerating. It can make it just frail. It's usually, sometimes it can be a secondary condition, caused by some cancers or something like that, which we've talked about in other chapters. But the most common is just that people get old, and it's sort of condition of advanced age as people get older and their bones don't regenerate like they used to. And so you'll see commercials on TV of like osteoporosis drugs, and there's always sort of advertised and marketed to people who are of advanced age, that kind of thing. And then osteoarthritis refers to joint pain and functional loss. So most commonly in the hips, knees, and hands. People can use crutches, canes, walkers, or get a joint replacement. So my dad just had his knee replaced. So when you hear people say like, oh, I got a new knee put in, what they were experiencing was osteoarthritis, and what the intervention was arthroplasty. So that's just a technical term for it. As far as the vocational consequences, the book talks about the reduced ability to walk distances or stand for long periods, that kind of stuff. These to me at least, and this may or may not be true for all of you, but when it comes to somebody experiencing a movement disorder or a muscle disorder of any kind, you can either accommodate that by using some mechanical things like a splint for carpal tunnel syndrome we talked about, a cane for helping for mobility, or a wheelchair for helping with mobility. But the intervention is really to say, like, what is the person required to do for their life? Both as a rehab counselor, this is like, for their job, what's their working requirements of standing, sitting, kneeling, stooping, walking, running, lifting, all those kind of like movement things, and analyzing what those are, and then saying, okay, how can we reduce that or accommodate that or just change the way a person moves or is required to move? That's one thing. But also we can think of the psychosocial consequences of that, which is if I loved playing on my church softball league, or if I loved going bowling and now I can't do that stuff anymore, how do I either continue to do it with accommodation, or how can I find new activities? And so even if you're not a rehabilitation counselor, like a vocational counselor who's looking at job requirements or something, you still will probably get people who are experiencing things like the requirement to slow down as they advance in age, and what that means for a person's self-esteem and self-concept. Those are still parts of most therapy. Well, I shouldn't say most. Many therapeutic environments. So worth considering. It's not just a vocational consequence as it says here, but it can have other can mean other things for the counseling environment. Back pain. So we'll talk about a couple different. We'll continue on our discussion of pain, because back pain, joint pain, chronic pain of all kinds of different related to movement disorders and stuff. These are so common. We'll talk about pain in the next lecture, but they're so common. Lower back pain, when people say, oh, I have low back pain, it's usually referring to the lumbar or sacral sections. So medically speaking, that's like, here and down. It can be caused by all kinds of different things. Posture issues, don't slouch. Teachers always tell you that in school, right? I'm a sloucher. When I sit in a chair, I like to bend over and then bend back and then lean over the side. I can't seem to sit still, which is something my mom always used to tell me when I was a kid. But I was a sloucher. At least I move around a lot, but still. So poor posture. Poor mechanics. So I used to work at Target when I was 16. And you'd always see those stickers on the side of a box. It says "Team Lift," and it shows these like a lightning bolts coming out of your back, and a guy's like bending over, and a lightning bolts coming out of his back, essentially saying Don't lift with your back, lift with your legs, and don't do it all yourself. Get somebody to help. But work-related injuries to a person's back are so common and so problematic. That's why they put stickers on the boxes. In fact, several years ago, I worked with a helicopter pilot who was flying for a medical, like a, what do you call it? Like the ambulance of the air, basically. He would go pick up people in remote locations and fly them down to, the hospital or whatever. And he was in the hangar, and one of the things you do with the helicopter is you put it on these little wheels to kind of cart the tracks. The two things that go down to the ground, and they stand on those little skis, or for lack of a better term. Well, you put those on little casters or wheels, essentially, and you lift up the back tail of the helicopter, and then you can kind of direct it and push it around, sort of like you're pushing a shopping cart, more or less. And he was lifting up on that, and it just, did something in his back, and all of a sudden he could not be a pilot anymore. I mean, that was an essential function of the job, so he just couldn't do it anymore. He was distraught because that was like a huge part of his identity, and he was a combat pilot in the military, and then he flew for this medical system, and now he didn't know what to do with himself. So anyway, common thing. Falls are accidents, self-explanatory. I'm gonna butcher the pronunciation of this, but spondylolisthesis, slippage of the vertebrae. There's some pictures in your textbook about what that means. When the vertebrae, they're all stacked on top of each other, and when they slip, parts of them can kind of slip out of place. Basically, it just sort of like says something's not in place here, and so when you try and move those as they're supposed to move, it can cause pain, and especially considering it's right next to the biggest nerve in your body, right? So, another one I'm going to mispronounce right here, spondylolysis. I should have probably looked that up on Google so I didn't look like such an idiot. But then again, I've said this before, I think it's okay for me to look like an idiot so that you can feel better about not being able to pronounce some of these big medical terms. Would it be great if I could? Yes, but I've never heard anybody say these things before. I've seen them on papers plenty of times, but I've never pronounced them. Could I go to Google and in 5 minutes just come back? Here, tell you what, I'm going to pause it. I'm going to go to Google. I'm going to hear the pronunciation of it, and then I'm going to come back and tell you what the right thing is. Just get the job done right. How about that? Okay, hold on a sec. Okay, here we go. I found it out. So this one is spondylolisthesis. You can say that one 10 times over again if you want to. And this one is spondylolysis. So there you go. That's how you that's how you learn things, is go to Google and figure it out. All right, continuing on. Other sources of back pain: arthritis, infections of bones in the spine, potentially tumors or herniated discs of vertebral discs. So all kinds of things. I'm sure there's more too. I probably missed something. Who knows? But the back is such a crucial part of our structure and how we use it, that if something goes wrong here, and there's lots of ways that it can go wrong, it can be really problematic, which is why it's a condition that you hear lots about. Okay. And it interferes with a lot of our life too, because it's such a crucial part of our body. So more on that later. We'll talk about interventions and things in the next chapter. Sciatica is pain that could be caused by something in the back, but it then radiates from the back to the hip and down the leg too. So sciatica is this, like, it could go down the left or right leg, but it feels like it's sort of shooting pain kind of down the leg, something like that. What we refer to as acute or chronic, we'll talk about this again in the next chapter too, but chronic back pain is categorized as something that's persistent pain that lasts longer than 6 months. In the next chapter, we'll talk about chronic pain in a little slightly different way, which basically means chronic pain is something that is not really fixable, and it also, if there is a way to cure it, it's something that, like, the normal means of making the pain go away, because oftentimes, like my example of someone gives you a Charlie horse in the arm, and the pain will eventually subside. It hurts for a few seconds or a minute or whatever, but then the pain kind of goes away. Even with injury, you break your arm, it hurts, and there's a little bit of rehab period, but eventually that pain will go away, and there's kind of a normal timeline for healing. chronic pain is not necessarily just 6 months, but it's if that pain extends longer than beyond what a normal healing period would be, then it kind of falls into that category of chronic pain. Also, there was one other point to make. I'm not sure, I forgot what it was, but we'll get to it in the next lecture anyway. So the categorization of pain is not necessarily just 6 months or longer. That's kind of an easy landmark for it. Oh, I know what the other one was. It's that if that pain has no real function or use in the body. So what I mean by that, it'll be chronic pain if it doesn't have that functional use. What I mean by that is that if we have like, let's say you're walking and you roll your ankle and all of a sudden your ankle hurts and you're like, oh my gosh, and then you're limping for a while, right? The reason that pain is there is to say, hey, there's been an injury here, and if you keep walking on your leg like you have been or on your ankle, then there's potential to re-injure it. So stop doing that. So my ankle tells my head, I'm going to make this hurt because I want you to be careful with me. And you say like, okay, yes, I'll be careful with you. I'm going to go sit with an ice pack and elevate and do all that stuff, right? Until it heals and the body says, okay, we're ready to go again. So we'll reduce the pain. It serves a very important function, right? We could talk about emotional pain the same way. It says like, hey, I'm spending too much time alone, and so I'm going to feel sad and lonely as an emotional response to say, hey, I should probably go be around some other people now. Or I'm getting too isolated for my own good, right? As social creatures, that's kind of our body's indicator to say like, maybe we should get on that and deal with it, right? So pain serves a very important function. However, chronic pain is often categorized as if there is pain that doesn't seem to be rehabilitative or helpful. In other words, it stays around long enough not to protect you, but just because it is. Then it just sucks and it doesn't need to be there. It's not doing any good for us. So it's a little bit, you can't really put a number on like how long or how intense or whatever, but it's a helpful way to say, this pain is no longer helpful. It's no longer helping me function better. It's actually making things worse. And so that's another way to kind of categorize this chronic pain stuff. By the way, it can be injury, can be congenital too. Lots of different reasons for pain. It can just exist for no apparent reason. Scoliosis is another condition, curvature of the spine. There's also pictures in the textbook about that, but it's, spine is supposed to be straight if you're looking at it from the back. If you're looking at it from a side posture, it's supposed to have curvature, but any irregularity in that curvature is considered scoliosis. And then the way to figure out how do we know what's going on with these, there's several different kinds of tests. Here's a couple of them. I put the terms out here so that you can see what the acronyms mean, but a CT scan, if you ever heard that, that's computerized tomography. An MRI is magnetic resonance imaging. And then an X-ray, of course we know what X-rays are. See the bones in the body. That's the idea. A little bit on back pain continued. We will talk more about this in the next chapter. We've already kind of talked about it as far as vocational accommodations, but there can be mechanical accommodations. So a new chair that supports your back with better lumbar support, more functions to recline and sit forward and, to increase, or I should say, support better postural sitting over time. Different desks, raising and lowering. There's all kinds of different options there. And then there's mechanical braces that can go over the body, especially if with things like scoliosis. If you put a brace in the body, it can help it kind of not move certain directions so that it's sort of encouraged to, for the muscles' sake and for other parts, it's encouraged to stay in a certain posture to promote health and safety of other body parts, or even sometimes to sort of correct things if they haven't, if they're not in the space they're supposed to be. Of course, rest breaks. Of course, ergonomic review of workplace. We've already kind of talked about that. And then posture training. What I mean by posture training is more along the lines of if you do physical therapy, oftentimes it's to increase the strengths of certain muscles so that it can help with poor posture. Like, for example, if you're going to do, this is a bad example, but I'm going to use it anyway. If you're going to do sit-ups, it's going to improve your core strength, and that means that you're probably going to be less likely to slouch in a chair or sleep improperly or just all kinds of stuff like that. So stronger muscles can improve better posture. That's kind of the idea. Even if you're not like, I mean, if you're like me and you're not really just striving for washboard abs, which is something I've never had and never will, it's less about the look, but more about preventing future injury or illness, and also preventing current, presently not as likely to experience things like pain and discomfort and extend functioning throughout life and that kind of thing. So, other musculoskeletal conditions. I'm going to watch the time here. We're doing good. Osteomyelitis. Sorry. I'm going to try to pronounce that one again. Osteomyelitis. That's how it works. It's a bacterial infection of the bone, common to diabetes. Peripheral neuropathy, if you remember what that means. Peripheral meaning the appendages, arms and legs. Neuropathy just means pain. And vascular insufficiency, which is a long way of saying vascular meaning blood vessels and the way the blood travels through the body. Insufficiency is not getting enough. So if you're not getting enough, you might have this osteomyelitis. I'm not going to go into descriptions of these, by the way. I'm just going to kind of brief over them. There's plenty more to know about each individual one and what they mean for a person, but that's kind of beyond the scope of what we're going to cover here. Fibromyalgia, this is one of those that it's a pain condition, and it's very misunderstood in the workplace and just cultural in general. It's basically a pain condition where pain exists all over the body in one particular place. It can come and go, and it's really just a confusing thing that happens to people. It's really not well understood of like where it comes from and how to treat it. And so it's one of those where we as counselors hear about people with fibromyalgia and they experience this sort of psychological side effect of being delegitimized. In other words, people think you're faking it a lot too. So we'll get to that, I guess. But it's thought to be due to an abnormal sensory processing in the central nervous system. In other words, we think something's going wrong up in the brain, but we don't really know. It's not like there's when you break your leg, you're like, oh, I think the pain comes from that broken thing, right? But when there's no cause that we can really put our finger on, it's like, well, something must be going on up here and it's just sort of like, it's kind of like a flickering light bulb in your house. It doesn't flicker on a normal pattern. It just kind of sits there, and like sometimes it's intense and sometimes it's just a little bit comes and goes with no real pattern to it. So we just don't really know even what it is or where it comes from. It's kind of like that, I guess, is an analogy for it. It can lead to things like easy fatigability, sleep disturbances, depression, and anxiety, which are very common. If you know somebody who's experienced fibromyalgia or lives with it, depression is one of those common things that people have to figure out, okay, how do I manage my condition enough so that I don't get this secondary thing of depression and anxiety, which can be functionally limiting in its own ways, right? Significant interference with the quality of life and interpersonal issues. So in past chapters, when we talked about things like you have pain and then you decide not to go to all your kids' baseball games, and then you're at home by yourself feeling guilty, and your kid's like, oh, where's dad? I'm missing. And then you're guilty because you're not participating in family activities, but also letting your son down. Your wife gets irritated because she's the one who has to go to the baseball games, and she's like, can you just please try and get up and do this? And you're like, no, I can't because I have this thing that I can't really describe. And then, you can imagine it's like that in a million different other circumstances where other people can get resentful or have a hard time or feel overburdened or overwhelmed or burned out. It's just, all those other issues that come into the counseling environment that can be very much a part of this. As far as what to do about it, though, it can be treated with antidepressants, anticonvulsants, sometimes sedatives. I love when the book says stuff like this. Also, counseling for improved locus of control, CBT, legitimization of the condition, is so important. I wrote it that way. But the book often kind of breezes over like, oh, counseling can be helpful. But for us in a counseling education program, I don't know about you, but I'm sitting there thinking to myself, okay, what does that counseling even look like? And the book really doesn't go there, right? So let's talk about this one for a minute. They do mention increased locus of control. So what does that mean? Locus of control is the ability for me to believe that I have something that I can actually do about this, as opposed to there's this condition that's outside of my control. We break this locus of control up into like internal and external. External locus of control, it's like I can't control that. I have to just let it happen or let it be. However, there are certain times when I can control certain things. So here's an example. Sometimes when people experience panic disorders, all of a sudden they're doing a thing, even if they know what's going to happen. Like I was recently presenting at a conference. I just got back actually, and the night before, my body started to, my heart rate goes up, and then right before the presentation, you start to get nervous. You feel a little lump in your throat. Maybe you get red in the face. You're sweating. You have a hard time breathing, and it feels like, okay, I don't even know. I can't control this. I don't know what to do about it, right? Or I know what to do about it. I know I shouldn't be scared, whatever, blah, 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 but it's just happening to your body. So there's kind of this experience of an external locus of control or being outside of the range of that I can even do anything about this stuff. An internal locus of control, which can be built, says, okay, if I'm having a hard time catching my breath, then one thing I can do is get some oxygen and force myself to take some long, deep breaths. That long, deep breath we've talked about this before, it can not only prevent or provide more oxygen to my brain, which is increases concentration and attention span, but also it can help put some pressure on my diaphragm, which can then stimulate the vagus nerve, which would kind of reduce this brain sensation of I'm out of control, right? So this is kind of the idea here. When we're talking about pain, we can say, well, what are the things within my control and what are the things outside of my control? Here's another example when it comes to pain here specifically. Sometimes we think, I can't prevent the pain from happening. However, what we can do in a therapeutic environment is to say kind of two things. What is your relationship to the pain? When you have it, do you just absolutely hate it and it makes you angry and then you get this nasty attitude? Or do you say, this pain is going to be with me and I'm going to treat it as if it's one of my annoying friends. I don't like their behavior. I don't like what they do. I don't even like them around sometimes. But they're with me and I have to deal with this, right? So you sort of take ownership or responsibility of your pain, just like you're like, this friend is going to be around me all the time, right? So the relationship to the pain is one part of that. You also have the choice of how you respond to that, right? So maybe the friend is not the best example, but imagine you have a child that has some behavioral issues and they're really stressful and they're really annoying. You love them, but you would love to have a break from them also, right? So it's just like your pain. I can't get away from my pain, but I don't have a good attitude towards it. And we get to choose that, right? We can't control other people, but we can control our response to that. And so when it comes to therapeutic interventions for pain specifically, we get to say, look, I'm in pain. I don't want to go to my kid's baseball game, but I've got to figure out at some point there's a balance between how much rest do I need to do to make sure I'm not in future pain so I don't exacerbate it, but how then do I also fill up my family cup and my social, going out with friends, the social activity cup? And how do I find meaning in my life in a way that allows me to not exacerbate my physical pain, but also not exacerbate my social isolation and those kind of things? What's within your control and what isn't? So hopefully that helps a little bit with those parts that just kind of get briefed over. CBT, let's talk about that. So the intervention of cognitive behavioral therapy often focuses on things like irrational thoughts, right? We'll just go to the cognitive therapy for a second here. Irrational thoughts, catastrophizing, black and white thinking, overgeneralizing, fantastical thinking. There's a whole list of other kind of cognitive strategies that we use to say like, the pain's coming back. Oh my gosh, the world is over. It's going to be terrible forever. Oh, and then we get, that's catastrophizing. It's going to the worst case scenario first all the time, And yet, yes, the pain is here. It's going to suck. It doesn't mean that I have to miss all the baseball games, even though I'm missing this one, right? So not going to that next level of panic and fear and overwhelm and all that kind of stuff. That's what CBT can be helpful with. So if you as a therapist say, okay, I'm familiar with all these strategies, and someone comes in and they're like, well, here we go again. I missed my son's first baseball game, and now I'm not going to get to participate in anything else for the rest of the year. Damn it. And you're like, okay, so what I see here is the condition of catastrophizing, and then you talk to them about it, do a little psychoeducation on what these different cognitive strategies are and how they're irrational and unhelpful. And then you can say, well, now that you notice yourself doing this thing, you work on that for a while, however long that takes. If you can notice yourself doing these things, then you can automatically choose to do differently. Say, oh, here I go again. I'm just imagining the worst case scenario, but in reality, I don't have to miss all of those baseball games. I'm missing this one, and this sucks and it hurts right now, but it doesn't mean the next one's going to be a total loss, right? So I'm going to feel my pain right now and feel my feelings, but when the next one comes around, I don't have to anticipate it being as bad. It might be, but nevertheless, it also might not be. So, you get to be aware of the thoughts and then choose different ones, right? Sometimes it feels like you're automatically just forcing yourself into different thoughts, which feels kind of disingenuous. But it's kind of like riding a bike. You have to make your body move and react in ways that you've never done before, and it feels uncomfortable, right? But then once you get it, it feels fluid and it's more liberating and you have more freedom and all that stuff. So that's kind of how CBT can be useful. It's also, the behavioral part of that too is just like, okay, when you have this pain and you go sit in your chair or your couch or you go to sleep so you can avoid the pain, something like that, sometimes the thing to do is just to not go to that place. So you change your behavior. Instead of going to my couch, I'm going to go over to this chair at the kitchen table and I'm going to stay there for a while so that I don't automatically do the thing that's most comfortable for me. So that's just an example of CBT. And then legitimization of the condition. When people come in, you will probably have people anticipating that they're not going to listen to you, that you won't care, that you won't believe them anyway, and they want you to believe them. But sometimes people even will fight you about believing them. So they'll say like, I feel this pain and nobody believes me, and you probably won't either. And you'll be like, nah, it's fine, I do. I mean, I can't not believe you. I'll just take you at your word. And they're like, okay, well, we'll see how that goes. You know what I mean? Like they kind of automatically reject any attempts of your kindness and your compassion and even if you make a logical argument to them of saying like, well, I could not believe you, but then there wouldn't even be any possibility for therapy to work. So I'm just going to do that even if I don't know. And they're like, okay, whatever. You know what I mean? It makes logical sense just to assume that people are telling the truth until you have reason to believe they don't, right? In this case, anyway, it's not always the right way to be, but in some cases like this, when people say like, I feel pain, you're like, okay, yeah, good. Tell me about that. What is that like for you? Tell me about what it feels like, whatever. You can embellish. If you have to embellish and make it a big deal and be dramatic about it, let's do that. Later on, we can work on reducing that through these kind of strategies. Let's reduce some of that embellishment. Let's take it at face value. But right now, just get it out because you need a listening ear to somebody who's going to actually care about you, right? Somebody who's not just going to be like, oh, gosh, again? You kidding me? That kind of stuff. So you will have people that resist those efforts, and that's part of this legitimization, which goes to building a relationship and building trust. And having them trust themselves that they even have a proper gauge for their subjective experience of pain. So I thought that was worth a little bit more explanation because the book just glosses over it and we don't actually get to see what that looks like. I've never seen somebody have one of these sessions specifically for chronic pain, and I would love to do that. I've done them myself, and I'm sort of fumbling my way through understanding other people's subjective experiences of pain, but I've never actually seen this. And it's one of those places where it's really hard to learn how to do this unless you understand the foundational principles of therapy and counseling and how these kind of things work. And once you get there, you'll say, oh, I can deal with this pain stuff, I think. I can help manage this a little bit. But that's why I spent a little bit extra time on that talking about it, because it's a little mysterious, or it always was to me anyway. So, vocational implications of fibromyalgia. Let's get back to what we're talking about here. Absenteeism, learning to pace oneself at work, flexible scheduling, reduced activity for some. Sometimes people need to maintain activity levels and they need to like get up off the couch and actually do stuff, or get up out of their office chair once in a while. That's why Fitbit gives you these warnings all the time. It warns my wife. She's like, you've been sitting for like 4 hours. Get your butt up and do some exercise, right? Some people need that. Same, and with fibromyalgia, that's certainly the case. And other people need to be told to calm down a little bit and settle down and listen to their body, listen to their pain as an important indicator of what their needs are. So depending on who your client is, you might have to say one or the other. Just might depend. Common to be labeled as malingerers. Malingering is that term of like just sort of making up pain as an excuse to get out of something or to get into something, or there's some incentive to say that I'm not well and I'm not doing okay. That's what malingering is. It's basically just lying about your pain. People are accused of lying, and that just creates problems. Of course, resentment from others too. Part of the role of a vocational counselor is if you are the kind of therapist who doesn't sit for 7 hours a day in your office and just hear about people's emotional problems, some counselors take all those same skills and they go onto the job site, and that boss who's like, I believe they're in pain, I trust him, but it's hard not to get resentful about it. And I'm struggling to know if I can even keep this person on my staff because of all of, like, they can't show up, and when they're here, they can't work because they're always sitting down. And as a counselor, I get to go, yeah, okay, tell me about that. You're not my client, but you're kind of my client, so, some boundaries there, but tell me about how frustrating that is, because, man, I would get overwhelmed with that too. I have people at my work. I teach here at the school, and sometimes I'm like, man, it seems like they're just kind of sitting around sometimes and not carrying their weight, right? So this is a common, normal thing for lots of people to experience, regardless of the setting. But then I get to do the same thing that I do for other people, is sort of this therapeutic stuff of saying, well, let's talk about that. Is that the way you really want to be thinking about yourself and about other people? Even if they aren't really holding their weight, how is the best version of yourself going to respond to this situation, right? Does it help you feel better by calling other people lazy? Does it help your business make more money? What's more important to you? What's your value? Do you care more about having employees that are loyal and that show up, and that you don't have to retrain over and over again? Or would you rather give somebody a little bit of extra accommodation in order to maintain that loyalty? What's more important to you? Performance, loyalty. There's all kinds of different ways you can talk to a boss about this, but that would just be an example of one of the ways that a counselor can help not just the person with the condition, but also their social environment. Okay, I spent a lot of time on that, so I want to check out how we're doing here. Management of conditions. We're going to talk about non-steroidal anti-inflammatory drugs like aspirin, acetaminophen, ibuprofen, Tylenol, all that kind of stuff, as opposed to steroids, which here they're called corticosteroids. We just, in a sort of colloquial way or sort of common parlance, how do I say this in a non-nerdy way? Common language, non-jargon. We talk about those as just steroids, but they're more appropriately called corticosteroids, so we're going to use that term. And then we'll also talk about opioids later too, probably in the next chapter, I guess. Another option is a hypobaric oxygen therapy, which is 100% oxygen delivered in a pressurized chamber. These things can be helpful for certain conditions. To be honest, I've never seen one of these, and I don't really know what this means exactly, like what conditions they'd be helpful for. But not all hospitals have these. It's not like it's a common thing to have a pressurized chamber that a person can be in getting 100% oxygen in. But apparently they're helpful, so know that they exist. Ask somebody else if you want to know what they do, because I'm not your guy, I guess. Or I'll just have to pause the video and go Google a little bit. I don't feel like doing it right now because I want to keep the video short and my recording time a little bit shorter. But physical therapy, of course, there's the kind of therapy that you do where they give you this giant rubber band and you're stretching your legs and all that kind of stuff, but also it can be very important to maintain bone structure. For example, somebody with a spinal cord injury, where exercise is done passively to them by another person in order to help maintain things like bone mass and muscle flexibility and all that kind of stuff. So that's just an example. We all know what a cast is. You get to sign them when other people get them in elementary school. You know what that's for. Assistive devices, of course, it's probably obvious. Orthoses, or some of you have probably heard that term before, but it's basically just a brace, more or less. It's an external thing to help maintain structure. So if you ever heard orthotics, it's like braces, you know? Um, in fact, braces that go on your teeth would be considered dental orthotics, something like that. So hopefully you get the idea there. Traction is another one. There's a picture of it in your book to help understand what this means, but traction is basically like a way to stretch. Sometimes you think of a cast as like, okay, if you surround this leg, this broken, say you broke your tibia, and you surround the leg with this thing, then it means it can't move. But sometimes when you have fractures that kind of like they break and they go like this, sometimes you need to stretch the skin out and the muscles that may want to contract in different ways. Sometimes you need to stretch that muscle out in order to maintain the right set. So that's an example of when traction is used. Also, if you have skin, if you get a cut, you know, it tends to want to kind of pull away from itself. If you've ever seen those, they're not Band-Aids, but they like stitches, for example. Let's use that. Stitches pull the skin back together. Well, traction is a very similar process to that, where it sort of like pulls things apart, holds them together in certain ways, and it's just one therapy to help things set properly. Help the muscles work and also the bones set in the right way and that kind of stuff. And then of course surgery. A bunch of different examples of what surgical interventions are involved here. I'm going to kind of fly through these because I have during this week, people in this class are going to be doing 2 lectures, so I want to get through this one pretty quick. Pain is a problem. Reduced activity can lead to further mental illness. We've talked about that. Basically, the potential for not only social isolation, but increased risk of obesity, which then comes with its own body image issues and social isolation issues and all that kind of stuff. So as part of that downward spiral, somebody gets a physical injury, and then they isolate, they eat too much, they don't exercise, and then it's just like more issues compound over time. Talked about family resentment, potential body image issues. There's probably a lot more we could talk about here, but I'm not going to at the moment. And then work conditioning is the last part. I think that's the last part. Yeah, work conditioning is the last thing that I want to mention. I know that I'm going to passively mention this at the end of a chapter, but this is actually an important rehab concept, which basically means if you're doing either mental health therapy or rehabilitation counseling, or sometimes I think there's maybe not the difference between the two, but nevertheless, work conditioning is the process of preparing somebody to return for work. So let's say I've been out of work for 2 years because I had this back injury and I'm dealing with attorneys and physical therapy, and I have had multiple surgeries for like spinal fusions or something like that. I haven't worked in 2 years, and all of a sudden I'm really comfortable getting up at 10 a.m. instead of 8. And all of a sudden I'm really comfortable at maybe getting up around the house for like 4 hours a day, but then I do a lot of sitting, and I have to go back to my job where I'm going to be standing for 6 hours a day or whatever it might be. Work conditioning is getting people back in the shape to go back to work. One of the things that I experienced after I left my doctoral program was, and even still to some degree this is still an issue, is that my sleep has been all thrown off. Like the time I go to bed and the time I wake up, and I was working at night, I was working in the mornings, and it was like just not on a regular schedule. And so part of my work conditioning is getting back to a regular routine schedule that provides consistency both for my body and for my mind to stay healthy. So as you look through these, things like work tolerance, work rate, control manifestations of my own conditions, so whatever conditions I'm living with, I can go to my workplace and also say I can expect to have this kind of pain, I can expect to be manage this kind of risk, whatever that is, getting ready to go back and consider those kind of things in the workplace. It's part of it. Increase confidence, learn how to use assistive devices. That's kind of all in the same ballpark here when we're talking about work conditioning. Some people think this is kind of a function of, it's partly sort of a team effort between physical therapy and occupational therapy, but for those of you who are coming from OT, which there are probably several in the class, there always are, it seems like, for those of you who are occupational therapists, what are the psychological conditions that we're thinking about? Like, I need to go back to work, but I'm freaked out about other people asking me questions, or I get so overwhelmed with the thought of like having to do all this work, or like I just get so exhausted, and then I get irritated when I'm tired, like we all do. And so how do I manage that? all that stuff about CBT and locus of control and all that kind of stuff, that's what counseling is for. That's where OTs and PTs just can't do that kind of stuff. And so this is where you can maybe have a place in this work conditioning process. So, okay, I am right at an hour, and I'm going to milk this for another 10 seconds just because I want to see myself stop on the 6-0. No other reason. So you can stop now if you want. But if you're going to wait, I will talk to you the next time. See ya.